So here is Dr. ANSHUL to deliver his talk. I request our chairperson to kindly introduce Dr. ANSHUL. I request.
Well-known figure now in Jhansi, and he always here to help us in number of cases. And I will invite Dr. ANSHUL to please deliver his talk.
I'd like to thank Team API. It's always a privilege to speak in this forum, because this is always very interesting, because we have a lot of discussions going on in this forum, and in and all there are multiple questions and discussions always there, and everyone is very eager to learn. And would also like to thank our chairperson for chairing this session. So today I have been allotted, and the forum is like to just highlight as an introductory slide that kidney disease is a great burden in type 2 diabetes. The prevalence is very high, and it is as high as 37% of albuminuria. So you can see that almost 3 out of 1 patients of type 2 diabetics in our OPD are having albuminuria. Now, if the patient have a type 2 diabetes and early CKD, it has been known that lifespan has been lost in the range of 16.9 in women and 14.8 in men. So this much lifespan could be loosened if we do not manage the kidney disease properly in type 2 diabetes. So early CKD detection becomes very important. Now this marker, that is albuminuria, I see generally gets missed in a routine type 2 diabetes management. We do kidney tests, we do liver tests, but we don't use UACR, which is recommended that we should be doing a UACR yearly in every type 2 diabetic patient. Now, why it is helpful? Because not only EGFR, but UACR also have a role, and you can see the stages of kidney disease that one patient, if you are checking just EGFR, and if EGFR is lying between 60 to 90, this patient is coming in a green zone when there is no albuminuria. However, if you did a UACR and it was found to be more than 300, that was in the range of macroalbuminuria, patient has shifted with the same EGFR, shifted to high risk in the orange category, which has got a high risk of having a CKD progression, and this needs a immediate intervention. So UACR becomes a very important tool and should be done, and now the cost is not also a factor. Now previously it was costing like 1400, 1500. Now it is costing just 500 rupees in the major labs. So it has been known that as albuminuria increases, EGFR decreases because of the increase in the fibrosis in the kidney. Now the albumin creatinine ratio is also linked with increased all-cause mortality. As UACR increase, there is an increased risk of all-cause mortality. As UACR increase, there is increased risk of CV mortality. So both combined together, if we check, we have to check at least annually, and all the major guidelines, including ADA, KDIGO, ACE guidelines, they recommend that at least we should be doing a yearly single white spot urine sample to measure albuminuria. Now, of course, when we are doing in some certain scenario, like patient was having a fever, infection, marked hyperglycemia, like HbA1c was very high, that time we are doing. That time we might find falsely elevated UACR. That time we should not be doing that patient. If the patient comes with a A1c of more than 10, that time we can avoid. Once the sugars are controlled, you check them. If the patient is having fever, infection, that time if we are off CKD progression, we have wonderful molecules now available. We have ACE inhibitors, ARBs, we have SGLT2 inhibitors. Now GLP-1 analogs have also been included in KDIGO guidelines. They have shown some response, and now one more molecule has come up, that is Finrenone, that is a MR antagonist. So what happened, how diabetic kidney disease happens, is because of the involvement of not only tubules but also glomerulars, also mesangial expansion, plus there is fibrosis at the level of myocardium and atherosclerosis at the level of vessels. So these things happens, and this all contributes to cardiorenal syndrome, and now there is one more entity, that is cardiorenal metabolic syndrome. So major driver of this has been found that there is an increased sympathetic overactivity which has been seen in type 2 diabetes, and this MR overactivation actually can be blocked by a MR antagonist. This can actually might prevent inflammation, fibrosis in the kidney, as well as improve the hemodynamic factors and reduce the albuminuria. Previously, we have other agents also. Aldosterone antagonist is not new concept, and these were actually tried. Spironolactone, there were multiple studies which were done in a kidney patient, but this was failed. These were all studies were failure, and there was no improvement in the kidney outcomes with spironolactone. Plus, spironolactone and eplerenone, these are steroidal mineralocorticoid receptor antagonists. Finerenone, on the other hand, is a non-steroidal. Spironolactone per se have a non-specific action because it has a steroidal action. It also blocks androgen receptors. So because of which you will find that male patient will develop gynecomastia with spironolactone. Plus there is a major effect on the BP. Plus metabolic parameters like hyperkalemia are seen much higher. So these are the problems which were seen with spironolactone. Next came the molecule like eplerenone, which has found to have a lesser impact on BP. It has found to have a lesser impact on the gynecomastia because it is much more lesser selective to androgen, more selective to aldosterone antagonist. Now this molecule finerenone is a non-steroidal, plus it has a more specificity, selectivity on mineralocorticoid receptor. So there is lesser side effects, there is no incidence of gynecomastia, very less impact on BP as compared to other molecules like spironolactone and eplerenone. Plus hyperkalemia was also found to be very low as compared to eplerenone and spironolactone. So there was a study which was done for finerenone, that was Figaro trial, to assess the kidney progression. So we'll be talking now. So this molecule has been added where it has shown a kidney benefit also, along with RAS blocker and SGLT2 inhibitor. Finerenone have shown a good benefit, and we will be talking about the details of all these trials. GLP-1 on the other hand, more data had yet to become, but KDIGO now still recommend that after SGLT2 you should consider a GLP-1 in a kidney patient. Previously we have all the trials with RAS inhibitors. You can see that there is a reduction in the eGFR progression. SGLT2 inhibitors, with all the SGLT2 inhibitors like canagliflozin, DAPA and EMPA, that was EMPA kidney, you can see that eGFR progression tends to reduce very early, and there was a 30% around reduction in the eGFR. However, you can see there is still a residual risk. This graph is not going in a negative way, it's still going in a positive way. So there is a lot of risk still is there, and this eGFR progression need to be further reduced by another agent. So residual risk still is remaining. It's not like we have added RAS inhibitor, SGLT2 patient will not progress into kidney failure. He will progress, but the rate of decline of eGFR will reduce with time. So this was, I will be talking about the trial that was Fidelity. There were two trials for finerenone. One was Figaro DKD trial. This was specifically done in a patient of diabetic kidney disease. Next came the Fidelio DKD trial, which was done as a CVOT trial for finerenone. So Fidelity trial, what he did is they combined both these trials together and they assessed the result. So this, you can see that Fidelity trial contains a lot of patients. You can see that Credence trial, there were 4,400 patients, DAPA CKD patient, 400 patients, 4,000 patients, EMPA kidney disease 6,000. On the other end, if Fidelity trial is taken into consideration, they have almost 14,000 patients into the consideration. So this was a trial where finerenone 10 mg or 20 mg once daily was given. The recommendation how to start will be talked by Sankar. It was compared with placebo, and median follow-up was done for 3 years. Major patients were those who were having macroalbuminuria. So you can see the baseline characteristic. Maximum have UACR of 515, eGFR of 50, well preserved eGFR, When it was observed, there was a good outcomes with fidelity trials that composite CV outcomes reduced 14% relative risk reduction, hospitalization to heart failure reduced, composite kidney point improved, and there was a reduction in the dialysis, going for a dialysis. Then they also assessed the heart failure. This was a patient of diabetic kidney disease who were having a heart issues. So new onset heart failure or hospitalization to heart failure tend to reduce. So now European Society of Cardiology, they recommends that Finrinon has a class 1A recommendation in patient with DKD to reduce the risk of hospitalization to heart failure. Finrinon have shown to reduce urine albumin creatinine ratio by 32% from the baseline. So this is a marked reduction you can observe within 4 months of giving a Finrinon. So you can see this plot where CV mortality, all-cause mortality, sudden cardiac death, all were tend to reduce with Finrinon when given to a diabetic kidney disease as compared to placebo. Now talking about the adverse effect, which was a major thing which has to be looked for because of the other molecules like spironolactone, neplirenon, there was high risk of hyperkalemia. So you can see that hyperkalemia was seen in 7% in the placebo, 14% in Finrinon group. But hyperkalemia leading to permanent discontinuation of the drug was seen only in 1.7% of the patient as compared to 0.6% in the placebo. Other adverse effects like acute kidney injury, gynecomastia, nothing was seen. No gastric side effects, nothing was seen with Finrinon. Only thing is there is a slight higher incidence of hyperkalemia, and that too in patients in the range of 1.7% only. So this risk of hyperkalemia has been reduced with this newer molecule, that is Finrinon. These were all the trials, Figaro and Fidelity outcomes. Now there was a real world evidence also have come up, which this molecule has been used in US in lot of patients, and this data is from the real world evidence from US, where they have checked the similar trial and similar patients profile as Figaro. What they found was there was more than 30% reduction in UACR. Finrinon has caused hyperkalemia only in 1.32% patients, and only 0.04% had hyperkalemia associated with hospitalization. So you can see that even the real world evidence suggests that there's only 1.32% increased risk of hyperkalemia with this molecule. So with this I will end my talk. Major key points of my talk was that albuminuria should always be recognized in a diabetic patient, and UACR is readily available. We should always be checking for a kidney disease patient. Early stage kidney disease is often missed, but if you detect it early, you can actually halt its progression and slow the progression of the kidney disease. One contributor of kidney disease increasing in the fibrosis is mineralocorticoid receptor overactivation. So on top of aldosterone antagonist, there is one more molecule which is inhibiting the mineralocorticoid receptor, has been found to be much more beneficial on top of ACE inhibitors. So these trials by Fidelity have shown that in patients who have eGFR of more than 25, they were given Finrinon and they were found to have a good CV as well as kidney outcome. Real world evidence has shown the similar results. Thank you. So I will ask